So we'll start with kidney disorders. Functions of the kidney. Before starting with the functions of the kidney, just this is a very small diagram, hand diagram, and we should know what are the actual parts of the nephron. The smallest unit of the kidney is the nephron. We all very well know. So this is the nephron. This is the glomerulus. This is the afferent arteriole. The blood is coming from the afferent arteriole. This is the tuft of capillaries impending into the glomerulus. This is the Bowman's capsule, and the urine gets filtered. Around the tuft of capillaries, the mesangium, and this dark one is the basement membrane. The basement membrane actually looks like this. Is the endothelial part. This is the epithelial part having the food processes, and this is the lamina. So this basement membrane. The urine gets filtered from here, going into the proximal convoluted tubule. The proximal convoluted tubule, this is the descending loop of Henle loop. This is the loop of Henle, ascending lip, distal convoluted tubule, and collecting ducts. And around this all is the interstitium. So this is the basic small unit or the nephron. Now, before going to the different renal disorders, we should understand what are the different functions of the kidney, so that if we know the functions, we can correlate all the clinical features to those functions and we can investigate accordingly. Excretion of the waste products, that is urea, uric acid, creatinine, bilirubin, toxins, drugs, metals, pesticides. These are the common waste products which are excreted in the urine. Water balance is the second main function of the kidney to maintain the water balance. If we are thirsty, then obviously the urine output will be less, or in the summer season, the urine output is less, while in winter or any season, the urine output is more. So in that way, the water balance is maintained. Electrolyte balance is the third major function of the kidney, especially the potassium and the sodium. Acid-base balance is the major function of the kidney, maintaining the pH of the blood or the body. Hemopoietic function, as erythropoietin is formed in the kidney. Endocrine functions of the kidney are as the kidney secretes renin, vitamin D, prostaglandins. These are the major endocrine functions. Regulation of blood pressure through water and electrolyte balance, and regulation of the calcium levels also, because calcium is reabsorbed by the kidney. So there is also regulation of the calcium and the vitamin D levels. Common clinical features, what a renal patient has: abnormalities of micturition, poor urine stream due to posterior urethral valve is commonly seen in infancy, or there may be dribbling of urine. Second common one is the edema. Nephrotic syndrome, abnormalities of micturition are only seen in congenital malformations, otherwise they are not that much seen. The most common feature, clinical feature a renal patient has is edema, and the most common cause of edema, especially starting over the face and then going down. So it is the nephrotic syndrome, glomerular nephritis, UTI. These are the common problems which have edema. Hematuria, gross or microscopic hematuria. Due to different renal conditions, patient may have gross or microscopic hematuria. Oliguria, urine output less than 1 ml per kg per hour. Dehydration may be the main cause. Glomerulonephritis, nephrotic syndrome, acute tubular necrosis, hemolytic uremic syndrome. These are the common causes of oliguria, leading to oliguria. Then dysuria, flank pain, may be due to ureteric calculi or UTI. Polyuria and polydipsia are commonly seen in obstructive uropathy, renal tubular acidosis, tubular diseases, hypercalcemia, along with diabetes insipidus and diabetes mellitus, which we very well know. But these are the other renal causes which leads to polyuria or polydipsia. Enuresis, hypertension in 85%. In children, per se, hypertension is very less, but if it is there, 85%, it is due to the renal cause. Growth retardation is a sign of renal disease. Anemia, maybe due to chronic renal failure, it is seen it is a refractory anemia because the erythropoietin formation becomes less. Abdominal masses are common clinical features because of renal masses. Maybe it is a cystic disease, polycystic or multicystic disease. Renal vein thrombosis gives a mass. Hydronephrosis, tumors, Wilm tumors. These are the common causes of abdominal masses because of renal problems. Now, the common investigations to be done in any renal case are urine examination, routine microscopy, and especially for the proteins or albumin. Kidney function tests include urea and creatinine, total proteins, serum cholesterol, ASO titer, C-reactive proteins, complement levels, electrolytes, ultrasound, plain X-ray abdomen, IVP or MCUG, desmopressin test rarely needed, radionuclide imaging, biopsy, and DMSA scan for renal scar. These were the investigations pertaining to any renal disease we can do. Now, before going to renal disorders, what is hematuria and what are different causes of hematuria? Glomerular hematuria, upper urinary tract sources of hematuria originate within the nephron. That is the glomerulus or convoluted tubules collecting ducts and interstitium. This is commonly called as glomerular hematuria if the blood is coming from there. Hematuria, because of glomerular causes, will be brown in color or cola or burgundy colored urine will be there if it is a gross hematuria. Proteinuria usually associates with this hematuria and may exceed 100 milligram per deciliter. RBC cast may be seen, deformed RBCs, epithelial cells, leukocyte cast may be seen if it is a glomerular hematuria. Causes of glomerular hematuria, renal disease like IgA nephropathy, PSGN, that is post-streptococcal glomerulonephritis, glomerulopathies, etc., are the renal diseases which are leading to hematuria. Multisystem disease, SLE, HSP, HUS, sickle cell, and HIV nephropathy, etc., are the multisystem disorders which leads to glomerular hematuria. Extraglomerular hematuria, it may originate from the pelvic ileal system, ureters, bladder, and urethra. Hematuria may be gross, blood clots are seen, or fresh blood is seen in this, or there may be terminal hematuria. Normal RBC morphology in glomerular, it is the crenated RBCs. Here the RBC morphology is maintained and it is the fresh blood which is coming out. Minimal proteinuria if it is the extraglomerular hematuria. On dipstick, it will be less than 100 milligram per deciliter. Now, causes of hematuria, upper urinary tract, tubulointerstitial, it will be pyelonephritis, interstitial nephritis, acute tubular necrosis, or nephrocalcinosis. For extraglomerular hematuria, it will be upper urinary tract. Then it can be vascular because of venous thrombosis, aneurysms, or malformations like hemangiomas. Crystalluria, calcium oxalate uric acid may also lead to upper urinary tract extraglomerular hematuria. Hemoglobinopathies can lead to hematuria. Anatomic problems like hydronephrosis, cystic disease may sometimes lead to hematuria. Tumors and trauma are also the causes. The lower tract of extraglomerular hematuria causes are infections, that is ascending infections, stones, trauma, coagulopathy, or heavy exercise simply also can lead to hematuria. Now, what is false positive hematuria? False positive hematuria, heme positive and heme negative. If it is heme positive, it may be hemoglobinuria or myoglobinuria. Heme negative, the causes are example drugs like chloroquine, ibuprofen, metronidazole, rifampicin, salicylates, etc. may lead to hematuria like color of the urine, but it will be heme negative. Food like beet and blackberries, etc. also can lead to heme negative hematuria. And metabolites like porphyrins also will, the urine will look like a hematuria urine. Now, proteinuria, we have to understand this before going to the renal disorders. Three types of proteinuria are there: transient proteinuria, orthostatic, and fixed. The dipstick is reported as negative, no proteins. Traces proteins will be between 10 to 20 milligram per deciliter. If we say it to be 1 positive, the proteins in the urine are 30 milligram per deciliter. 2 plus if it is between 30 to 100 milligram, 3+ if the proteins are between 300 to 1000 milligram, and 4+ if the proteins are above 1000 milligram per deciliter in urine. Transient proteinuria, protein remains in the urine for a few days. Causes may be fever, exercise, dehydration, CCF, seizures, stress, cold exposure. The proteinuria usually do not exceed 2+. Mechanism is unknown and no treatment is required for transient proteinuria. Orthostatic proteinuria, it is the most common cause of persistent proteinuria in school-age children. Children are usually asymptomatic. In supine position, they excrete minimal amount of proteins. In upright position, they excrete proteins up to 10 times, that is 1000 milligram per deciliter per day. Hematuria, hypertension, edema, maybe hypoalbuminemia, and renal dysfunction is absent. There won't be any hematuria, there won't be any hypertension, edema, or any other renal signs and symptoms, but only patient will have orthostatic proteinuria. Causes are not known. It is said that partially renal vein obstruction in the upright position may be the cause. Fixed proteinuria, significant proteinuria on a first morning urine sample for 3 consecutive days, that is more than 1+ of proteins in urine, is called fixed proteinuria. Fixed proteinuria indicates renal disease. Causes of proteinuria, glomerular causes are membranous glomerulopathy, membranoproliferative glomerulopathy, that means the glomerular basement membrane is affected. Focal sclerosis of the basement membrane, post-streptococcal glomerulonephritis, or Henoch-Schönlein purpura may be the causes of proteinuria. Tubular causes, Loeys syndrome, cystinosis, acute tubular necrosis, poisonings, etc. These may be the causes. In these patients, kidney function test, urinary protein to creatinine ratio, complement levels, renal biopsy should be done along with ultrasound, and blood pressure monitoring should be done. Now coming to renal diseases. Nephrotic syndrome is primarily a pediatric disorder and is 15 times more common in children than in adults. Incidence is 2 to 3 per 1 lakh children per year. Now it might have increased. Majority of the affected have steroid sensitive minimal change disease. It is characterized the minimal change nephrotic syndrome. We are going to discuss about the minimal change nephrotic syndrome. So it is characterized by massive proteinuria, leading to hypoalbuminemia, leading to edema and hyperlipidemia. Pathogenesis of minimal change nephrotic syndrome is obscure. There is indirect evidence to suggest involvement of T lymphocyte pathways, causing neutralization of anionic charges on glomerular capillaries of the glomerular basement membrane. Therefore, there is increase in permeability to albumin, as because of this pathological changes, the food processes get effaced. 90% of nephrotic syndrome are idiopathic. There is no cause. Out of these 90%, 85% are minimal change nephrotic syndrome. 5% are mesangial proliferation. We'll see mesangial proliferative changes, and while in 10%, focal segmental glomerulosclerosis will be seen. Amongst those 85% minimal change, as such, on electron microscopy, no changes will be seen much. In the last two conditions, the course is less satisfactory. Steroid resistant patient will become steroid resistant, and they may land up into chronic renal failure. 10% have nephrotic syndrome secondary to glomerular diseases. As I said, 90% idiopathic. The 10% will be having glomerular diseases such as membranous nephropathy or glomeruloproliferative disorders. The course is less satisfactory, and again, these patients will also land up into renal failure. In minimal change nephrotic syndrome, glomeruli appear normal or show minimal increase in mesangial matrix and cells. On electron microscopy, effacement of the food processes is seen, and therefore it is also called as food process disease. Endothelial cells look swollen, while epithelial cells look vacuolized. In focal segmental glomerulosclerosis, segmental scarring causing obliteration of the capillary lumen, IgM and C3 deposits in areas of sclerosis will be seen. Now, mechanism of edema, as this is the major clinical feature of any renal disease. What is the mechanism of edema? Due to immune deposits, the food processes get effaced, causing protein filtration, especially albumin. So it's a selective albuminuria in minimal change nephrotic syndrome. Normal person do not contain albumin in their urine. Proteinuria is heavy, that is more than 1000 milligram or 1 gram per meter square per day. This proteinuria, so much loss of protein will lead to hypoalbuminemia, and that will lead to decrease in the serum albumin to the extent of less than 2.5 grams per deciliter. Now, so much of albumin has reduced, this will decrease the plasma oncotic pressure because plasma proteins are said to maintain the oncotic pressure. Because of decrease in oncotic pressure, there is extravasation of the intravascular fluid. This leads to hypovolemia. This hypovolemia causes two things: decrease in the renal perfusion, which activates the RAS system, and aldosterone stimulation causes sodium and water reabsorption from the DCT. Again, water goes to the interstitial space and it will increase the edema. Secondly, also due to volume depletion, ADH is stimulated. This reabsorbs water and again the water goes out into the extravascular compartment. Hypoalbuminemia induces hepatic synthesis of beta lipoproteins. This results in hyperlipidemia. Also, there is urinary loss of lipoprotein lipase leading to decreased lipid catabolism, and therefore there is hyperlipidemia. Also, there is loss of vitamin D, calcium from the urine, erythropoietin and iodinized protein in the urine, leading to anemia, calcium deficiency, hypothyroidism, etc. The clinical features, usually we find that males are affected more than females, 2:1 ratio, 2 to 6 years is the common age. If nephrotic syndrome is occurring below the age of 2 years or above the age of 6 years, then it may not be a minimal change nephrotic syndrome. It may be a steroid dependent or resistant. Initial episodes and relapses may follow minor infections. Reactions to bee stings, insect bites, or IV poisons are known to initiate the episodes. Edema, periorbital, then it becomes generalized, that is called anasarca, or on legs, that is pitting edema. Pleural effusions, ascites, scrotal edema may be the extreme end of edema. There will be decrease in urine output, anorexia, irritability, abdominal pain, diarrhea. These are the common features, and diarrhea may worsen the condition. Hypertension is not a common feature of minimal change nephrotic syndrome. Commonest conditions associated with idiopathic nephrotic syndrome are allergies, drugs like NSAIDs, malignancies, Hodgkin's, CA bronchus, etc., viral infections, immunization, diabetes mellitus, myasthenia gravis. These all can precipitate or they can be triggers for nephrotic syndrome. Now, differential diagnosis. Patient has decreased urine output, patient has edema, anasarca, breathing difficulty because of fluid retention. So what are the other differential diagnoses on the clinical basis and examination? The other differential diagnoses are congestive cardiac failure. But in CCF, if we do a urine output, a urine routine microscopy, there won't be any protein in the urine. So urinary proteins will be nil in cases of CCF. And of course, you may get certain murmurs or other cardiac clinical features. The liver will be palpable, JVP will be raised, there will be murmur. So all the other signs of congestive cardiac failure will be seen. Kwashiorkor also has generalized anasarca, but the age is below the age of 2 to 3 years. And definitely we in this also again there won't be any urinary protein, but the total body protein will be less because of decreased absorption. So we'll get history of malnutrition. Protein losing enteropathy or malabsorption syndromes also can lead to edema. Hepatic failure leads to edema, but definitely patient may have jaundice, coagulopathies, hepatomegaly, and the liver function test will be derailed, and there won't be any urinary protein positive. Acute and chronic glomerulonephritis is a part of renal diseases. Insect bite with anaphylaxis also is a cause of generalized anasarca. Now, how will you be further proceed? Investigations. We'll first and the foremost important investigation is the urine routine, in which we'll get 3 plus or 4 plus of albumin on examination. Microscopic hematuria may be seen in only 20% cases. Serum albumin less than 2.5 gram per deciliter. Total body proteins are decreased. Creatinine may be normal, rarely mildly increased. Serum cholesterol triglycerides will be higher. Complement levels are normal in minimal change. IgM will be more, IgG will be normal or down. Investigations further renal biopsy not indicated in minimal change, but indications of renal biopsy are atypical clinical features at onset, age less than 1 year or more than 10 years at onset, persistent hematuria, low complement levels, hypertension, kidney function tests are deranged, persistent albuminuria in spite of giving steroids for more than at least 1 month. These are the indications for renal biopsy. Mild to moderate edema can be treated on OPD basis. Diet, salt restricted diet, high protein diet, low fat diet, everything is explainable because we know why we are restricting salt, why we are giving proteins, and why low fat diet. Proteins 1.5 to 2.5 gram per kg per day. Fluid restriction in cases of severe hyponatremia. Plasma albumin 20% can be given in cases of severe hypovolemia due to rapid loss of proteins. Diuretics if edema is moderate to severe. Diuretics should not be given to patients with diarrhea, vomiting, dehydration. Furosemide 1 to 3 milligram per kg if to be given for longer durations. Spironolactone is added to avoid hypokalemia. Albumin plus furosemide is used in refractory edema. Also, immersion of body up to neck in bath can be helpful. Treat infections as patients are likely to have severe infections. Common infections include peritonitis, cellulitis, pneumonia. Most common pathogen being streptococcal pneumonia, E. coli, influenza, and viral infections. Steroid therapy is the mainstay of nephrotic syndrome treatment. According to we will give prednisolone 2 milligram per kg per day in 2 to 3 divided doses for 6 weeks. This is for the first attack of nephrotic syndrome. Then after 6 weeks, 1.5 milligram per kg alternate day for the next 6 weeks. 90 to 95% of minimal change respond within 10 to 14 days of starting the treatment. Proteinuria, edema will decrease, blood pressure is monitored, Cushingoid features will be seen. Parents' education for the nature of disease, for the treatment of the disease, for the side effects of the treatment like steroid side effects, should be counseled for. Promote physical activities, and remission and relapses should be told about. Now, what is remission? It is said when proteinuria is less than 4 milligram per hour per meter square or 0 to traces on elbow sticks for 3 consecutive days, then it is remission. Steroid responsive complete remission achieved with steroid therapy is called complete responsiveness. Now, what is relapse? Proteinuria more than 40 milligram per meter square per hour or on elbow sticks 3 plus for 3 consecutive days after having been in remission. Remission has completed. Again, the patient has for 3 consecutive days after some time proteinuria, then the patient is in relapse. Frequent relapses are said if they have 2 or more relapses within 6 months or 4 or more relapses more than 1 year in 1 year. Steroid resistant failure to achieve remission following 4 weeks. Nowadays we say 8 weeks of prednisolone followed by 3 methyl prednisolone pulses 2 to 5. If the patient still have proteinuria, then that is said to be steroid resistant. 2 to 5% either do not respond or later cease to respond. Steroid dependent, 15% of patients remain in remission only on continued prednisolone therapy and relapse when dose is decreased or stopped. Within 2 weeks of stopping the drug, patient will have again proteinuria. That means it is steroid dependent. Management of relapse. If urine shows 3 plus or 4 plus albumin for more than 3 days plus edema, start prednisolone 2 milligram per kg per day in divided doses for the 2 weeks. Then 1.5 milligram per kg per day, alternate day for the next 4 weeks. This is the complete 6 weeks management. Initial treatment plus relapse treatment, an alternate day prednisolone is tapered to a minimum of 0.3 to 0.7 milligram per kg that keeps patient in remission without steroid toxicity for 9 to 12 months. If frequent relapses cause steroid toxicity, the following drugs are considered. Levamisole 2 milligram per kg alternate day for 2 years with low dose steroids. Cyclophosphamide plus prednisolone, cyclosporine plus prednisolone. Now we should see for what are the complications in cases of nephrotic syndrome. Massive edema, we have to give Lasix plus albumin. Infections due to edema, steroids, treatment with antibiotics proper. Immunization after 6 weeks of stopping the steroids. Thromboembolic phenomena is the third complication due to hypercoagulation. Acute renal failure, rapid diuresis, and acute gastroenteritis may aggravate and precipitate renal failure. Or if the cause is not minimal change, it is something else, patient may land up into renal failure. Steroid toxicity leads to Cushingoid features, so that is one of the complication. Short stature, long-term complication, hypertension, osteoporosis, cataracts are the long-term complication of steroid treatment. Thank you very much.